Hello, welcome to this program where we will be addressing new horizons in high-risk hormone receptor positive, HER2 negative early breast cancer, where we discuss risk stratification for early identification of novel treatment strategies. My name is Carlos Barrios, and I'm a medical director and principal investigator of the Oncology Research Center and Hospital San Lucas, and Director of Clinical Research and Oncologist of the Oncoclinical Groups in Porto Alegre, Brazil. And I have the pleasure of being joined by Professor Nadia Harbeck from the University of Munich, Germany, where she is head of the Breast Center, the Oncological Therapy Clinical Trials Unit, and the Center for Hereditary Breast Cancer and Ovarian Cancer. I'm also joined by Professor Chiun-Sheng Huang, Chairman of the Department of Surgery at the National Taiwan University Hospital and College of Medicine, and Director of the Breast Cancer Center of National Taiwan University Hospital. Thank you both for being here. It's a pleasure to have you. This is our agenda, and we will be discussing first, what risk assessment and stratification strategies can be applied to identify patients with high risk hormone receptor positive early breast cancer. Second, we will be discussing what are the latest guideline recommendations and current treatment strategies for high-risk hormone receptor positive disease, and why are new therapies needed for these patients. Lastly, we will address how might novel therapies influence the future prospects for patients with this kind of situation, high-risk hormone receptor positive HER2 negative early breast cancer. Let's start with the first section, where we will be addressing what risk assessment and stratification strategies can be applied currently to identify patients with high-risk early breast cancer. Here, you can see that hormone receptor breast cancers that, as you all know, represent the large proportion or the largest proportion of patients with breast cancer. And here you can see that early disease can be classified as having different risk levels, different risk of recurrences. Furthermore, recurrence can be seen in this kind of populations early, and characteristically, some of these patients have late recurrences as well, as you can see in the chart. Here you can have an example of showing that following 5 years of endocrine therapy, you can have a significant residual risks. And here you see evidence that both tumor size, T1 and T2, and number of lymph nodes involved have significant impact in what happens with these patients. So within this situation, let me start the discussion asking Nadia, in today's practice, why is it important that we perform risk stratification and identify patients with high-risk early breast cancer in this kind of situation? Nadia.
I mean, in the luminal early breast cancer, I think we have several questions that we need to ask before we start any treatment. First question, obviously, is who needs chemotherapy in addition to endocrine therapy? And the second question would be who needs more than standard chemo and standard endocrine therapy because they're of high risk. So we need to do a risk assessment and certain levels to have the final treatment concept. And then I think the major risk factors I can see is the clinical tumor burden. I think that is something that we need to assess first, like lymph node involvement, tumor size, great, and obviously the immunohistochemical analysis. And then we move on to more detailed analyses, then also supported by biomarkers. But I'm curious to see, because we practice in different parts of the world, to hear Chiun-Sheng's opinion on that as well.
Certainly, that's very important, Chiun-Sheng, and obviously we need to agree on the idea that not all patients are the same, particularly in this early stage, and we need to define criteria to select who are the patients that we're going to be worrying more about? How do you do that as a surgeon in Taiwan?
I think we all know that lymph node status and tumor size, of course, is a prognostic factor, very important. But since the understanding of molecular subtype and some biology factors like Ki67, and we get to know that maybe patient with the same tumor size and lymph node involvement, maybe they will be different if their Ki67 status is different, or if the multi-gene assay result is different. So I think nowadays in certain patients, say with no negative or 1 to 3 nodes, I think we will consider the multi-gene assay or something. If patient cannot afford the expensive multi-gene assay, maybe so-called the HC4, the ER, PR, HER2, and Ki67, that altogether will help us to determine whether they are high risk and they need chemotherapy or not. But for the patient with lymph node involvement more than 4 nodes, I think they are extremely high risk. Probably multi-gene assay cannot be applied in those patients, I think.
Thank you, Chiun-Sheng. That's a very important comment. But Nadia, let me address this next question to you. We have been having this question for decades now. What to do after a patient presents with breast cancer, and how can we deal with the risk these patients may have of developing recurrent disease? And recently, over the last years, decades actually, we have been able to identify some biomarkers and genomic assays, as Chiun-Sheng just mentioned, to help us defining this prognosis and defining potentially what therapies to select for these patients. So, how does this biomarker testing, other stratification tools such as genomic assays that have been developed, change the way we assess and identify these patients with high risk early breast cancer?
I think that's an important point. And if I look back, I've been working with biomarkers in early hormone receptor positive, HER2 negative breast cancer now for several decades almost. And very few factors actually came and stayed. And so I would say the first thing I want to know is it a full axilla? Is it probably more than 4 and more lymph nodes? Then I don't think we need any additional biomarkers for the time being. We would go for chemo, followed by endocrine therapy, and then endocrine-based therapy in addition. If we have like a limited nodal involvement or node negative disease, then it becomes more complicated, because then a chemotherapy decision can only be made by adding factors like genomic assay and or Ki67. And I'm glad you brought that up, and also Chiun-Sheng has mentioned Ki67. It's been around for a while. It's an inexpensive factor, and it's become more and more important. It's been known that it's prognostic in early breast cancer for quite a while. And interestingly, in the recent Monarch E study with abemaciclib in the together with endocrine therapy, which led to the approval of abemaciclib in early breast cancer, it was shown that even in patients with very high clinical risk, like up to 3 nodes and additional risk factors or 4 plus nodes, Ki67 is actually prognostic. And I wasn't so sure that that was going to be the case. So it shows what a potent prognostic marker is. In Monarch E, it was not predictive for abemaciclib benefit. We know it can be predictive for chemotherapy benefit, although we would not use it to indicate chemotherapy in that way. It's become a bit a point of discussion, because standardization is not well done everywhere around the world. Some countries are just starting with Ki67. But I think from the experience in Germany, we've had round robins for quite a while. I think that we have a good standardization, and it's very, very reliable in low Ki67, like 10% or lower, or high Ki67. And for this intermediate risk group between like 15 and 20, 25%, I would not trust Ki67 for a chemotherapy decision, I would always add a genomic assay in these limited nodal burden patients. And lastly, we just published the ADAPT study in the JCO, the endocrine response testing by looking at Ki-67 after short preoperative endocrine therapy, and then looking whether it's 10% or lower, which would be endocrine responsive tumors. That is also helpful, in particular also in settings where you don't have the resources to do these genomic assays on every patient. So it's an important factor. We have identified some areas of utility, so I think we'll move that forward. And lastly, ctDNA has become an issue of discussion in the metastatic setting. I would argue in early breast cancer, we're not quite there yet to implement that in clinical practice.
Fantastic answer. Thank you both for the discussion. And as if I may summarize, I think that we all can agree that risk stratification and identification of patients with high risk early breast cancer as early as possible is absolutely critical, central to determine patient prognosis and definitely helping us making treatment decisions. Having said that, it's not necessarily easy. There are certain situations where we can use genomic assays, and there are certain situations, importantly, for example, in a patient with more than 4 positive loads, where these assays do not necessarily help us, as the indication of chemotherapy is already established by the number of nodes that are involved. Importantly, Nadia's comments regarding Ki-67 and the new evidence with Monarch E suggesting that a group of patients with a high risk of recurrence based on Ki-67 and some of the other clinical factors like tumor size and nodal involvement actually can identify a group of patients that actually benefits from the introduction of abemaciclib to chemotherapy in that study in particularly, and to hormonal therapy, traditional hormonal therapy in that situation. So extremely important to recognize this situation of identifying risk and stratifying on our patients in order to define the best possible treatment for them. In the second section of this program, we're going to be discussing what are the latest guideline recommendations and current treatment strategies for high-risk hormone receptor positive HER2 negative early breast cancer, and why are new therapies needed for these patients. If you look at the treatment journey of patients with hormone receptor positive HER2 negative breast cancer, there are a number of alternatives where these patients can be managed. Neoadjuvant chemotherapy is one of the possibilities, and the definition for that depends, as we wouldn't be discussing, of some clinical pathological characteristics. More rarely, patients may be treated with endocrine therapy in the neoadjuvant setting, although that's not necessarily the most frequent indication. Most patients that we're going to be discussing are treated with surgery as the first approach. After neoadjuvant treatment, patients are generally treated by surgery, obviously, and after surgery, patients complete local therapy with radiation therapy. Those patients that have not received chemotherapy in the neoadjuvant setting can receive, after local therapy is completed, adjuvant chemotherapy or necessarily receive endocrine therapy either as a single treatment after radiotherapy and surgery or following adjuvant chemotherapy. Within this scenario, I think that we can address with our panel a number of different questions. And let me start with Chiun-Sheng. In your region, what are the initial treatment options for a patient with hormone receptor positive, HER2 negative early breast cancer, and how these options are influenced by individual disease characteristics and preferences? What can you tell us about what you do in Taiwan in this situation, Chiun-Sheng?
Yes, I think usually we will only offer surgery upfront surgery for the patients with hormone receptor positive, HER2 negative patients, because the PCR rate for the hormone receptor positive, HER2 negative breast cancer is quite low. And so patients, they will feel disappointed after extensive chemotherapy in front. So usually we offer surgery first. But for some patients who likes to downstage and to have a better cosmetic outcome for their breast, I think even the PCR won't be achieved, but partial response actually is good for a patient, even is hormone receptor positive, HER2 negative. So at that time, we will consider neoadjuvant chemotherapy. And also, if ultrasound shows lymph node positive or a PET scan show that the patient has positive nodes, then although the PCR rate of the lymph node is also not high, but actually about 1/4 of patients might get PCR after neoadjuvant chemotherapy. So in that situation, we will consider neoadjuvant chemotherapy. But we usually talk to the patient that maybe she cannot expect that there is always a PCR because PCR is low. But for patients with very old age, sometimes they refuse chemotherapy. And then I think that is the only situation we will consider probably neoadjuvant hormonal therapy for the patients. Because I think nowadays we don't have the data to prove to us that we can get rid of chemotherapy for sure that in most of the patients. Because if, for example, nowadays the multi-gene assays only is good for patients who have upfront surgery. And I think although there are some studies to show that multi-gene assay may help to predict the benefit of chemotherapy in some patients through the core needle biopsy. But actually, that is quite small studies, and most of the time is not really prospective studies. So basically, we do surgery first unless patient want to downstage the tumor size or lymph node status. And for patients who really refuse chemotherapy or intolerance of chemotherapy, and then we will consider a neoadjuvant hormonal therapy. But of course, Nadia just mentioned about the ADAPT. I think she can talk more about that.
Thank you, Chiun-Sheng. Fantastic answer. Nadia, the Germans have been very well known for a number of things, and certainly neoadjuvant therapy. I guess you have taught all the world on applying this concept to the management of breast cancer. What are the key factors, in your opinion, that determine your choice of neoadjuvant systemic therapy, in particular in the patients with hormone receptor positive disease?
Thank you for that compliment. I think we're so good in the neoadjuvant clinical trials because we have had these breast centers where everybody works under one roof now for several years, and that is really a good concept. So we can sort of decide what to do with the patients. With regard to neoadjuvant chemotherapy in the German guidelines, and you mentioned the AGO guidelines when you went through the algorithm, they clearly state if you have a chemotherapy indication, please give it in the neoadjuvant setting because you get a feel for the response and it may positively impact your surgery. So in the hormone receptor positive, HER2 negative early breast cancer space, it's not so easy, like Chiun-Sheng already said, because you can only indicate chemotherapy if you have a chemotherapy indication, and that's only clear if you have, like, for example, the clinical equivalent to 4+ nodes, so a full axillar. If you only have limited nodal burden or node negative disease, you're not so sure about the chemotherapy indication. If you're still thinking about neoadjuvant chemo, you could do, like Chiun-Sheng said, the genomic assay in the core needle biopsy. In the ADAPT study, we've done that in over 5,000 patients and have had good success rate, over 95% return of results. So it's technically feasible, and it correlates very well with the core biopsy with the larger tumor specimen. Then you can also do the neoadjuvant, like this short preoperative ADAPT approach, endocrine therapy, 3 to 4 weeks. And then if the patient has a high genomic risk or is endocrine non-responsive tumor, you want to go for chemo, you can do that in the neoadjuvant setting. Otherwise, and I would completely agree with Chiun-Sheng had said before, I would always, if I'm not so sure, go for primary surgery, collect all the information, because the one thing that drives us towards neoadjuvant chemo in the other subtypes of breast cancer is that we have escalation regimen after surgery. And actually the escalations we have in the luminal early breast cancer space, like in the germline BRCA mutation carriers or in the clinical high risk patients, we could do independent of when we administer the chemotherapy. So it's actually not necessary to have that PCR information. And it's few patients with a PCR. If you have a high clinical risk but an endocrine responsive tumor, in ADAPT we only had 5% PCR. So it's not going to make the tumor shrink much either. So complicated subject. If you're not sure about the chemotherapy indication, I would always go for primary surgery and collect all the answers properly.
Fantastic. I think that that's very helpful. But I have a last question in this subject that I would like to ask both of you, and I would like the short answers of both of you. Nadia mentioned this issue that I want the audience actually to participate in this. In terms of systemic therapy options, what are the remaining unmet needs to address for these patients with high risk hormone receptor positive disease? Chiun-Sheng, do you want to start?
Yeah, I think we know that for the hormone receptor positive HER2 negative patients, although their survival is relatively good compared to the other subtypes, but actually they recur gradually still, even after 10 years, 15 years, 20 years. So that means we, in addition to extension of the hormonal therapy, maybe we need to have something like CDK4/6 inhibitors try to improve the outcome for this patient, not only in the short term, but also in the long run.
Nadia, what are your unmet needs in these patient populations in terms of high risk, particularly hormone receptor positive patients?
I think first we have to realize that there is such a thing as a high risk population in hormone receptor positive, HER2 negative early breast cancer, which has an unmet medical need. And I realized that when we looked at our Plan B results, where we saw that patients with these highly proliferating luminal B tumors, actually after 5 years, even though they had standard chemotherapy, standard endocrine therapy, they were still doing even worse than the triple negative population. And like Chiun-Sheng said, after 5 years, we only capture like half of what's going to happen to these patients, whereas in the triple negative field, mostly all the relapses had occurred that far. So it's a high unmet medical need. And I think sometimes in the tumor boards, we don't realize that because we're so driven by HER2 positive, by triple negative, that we forget that these luminal Bs actually have an unmet medical need. And I'm really glad that we now have options for them, like for the germline BRCA mutation carriers. We do have the data from the Olympia study showing an overall survival. We saw that at the ESMO virtual plenary in March of this year, overall survival benefit of about 3% after 4 years. And we do have the data from the Monarch E, which we already had discussed earlier, which show about a benefit at 3 years of already 5% or so, depending on which risk group you look at. So very promising data. And I hope that these data will help us to make these patients that we couldn't help in Plan B, help them better in the future.
Thank you very much, both of you. Let me summarize this very interesting and important discussion. And let me start with saying that we need to identify these patients. We need to recognize that not all these patients are the same, and some of them actually have very high risk of recurrence and need very special treatment in that regard. Recent guidelines are evolving to try to help us in defining the best or optimal approach for hormone receptor positive, HER2 negative early breast cancer. AGO, the ESMO, and the Pan-Asian adapted ESMO guidelines should be able to help us in the near future on how to best manage this kind of patients. Importantly, as was mentioned, genomic profiles and biomarkers, even though not necessarily perfect in this scenario of early disease, to decide on neoadjuvant systemic therapy, there are other factors that we used much more practically in that situation, like tumor histology, grade, stage, hormone receptor positive HER2 situation, and certainly trials are ongoing addressing all these issues. And probably the best way to describe this is that probably we use these situations or these factors together in order to make a final definition. And obviously, important to recognize the gaps that we still have in this area, particularly related to treatment resistance and disease recurrence that continue to be a problem. And we need to continue to look for better alternatives to treat these patients, identify these patients, and treat these patients in an optimal way. In this next section, we will be discussing how might novel therapies influence the future prospects for the management of patients with high risk, hormone receptor positive, HER2 negative early breast cancer. We need to recognize that over the last few decades, we have come to understand the complexity of estrogen signaling, of endocrine signaling. And other than just the simple activation of the estrogen receptor as a transcription factor, a number of other pathways have been recognized that have a significant influence in the way the estrogen functions within the cell, and certainly the tumor cell. Certainly, the interference of these other pathways is significant, and we have been able to demonstrate that inhibition of some of these other pathways actually have significant impact on the way patients actually behave. You have the example of PI3 kinases. We have the example of cell cycle inhibition as the two main pathways that have been inhibited together with endocrine therapy, traditional endocrine therapy, with significant impact in patient outcomes. Certainly, at the same time, we need to recognize that new drugs are being developed, particularly the SERDs, trying to substitute the old fulvestrant that we have been using for many, many years, to interfere with these pathways as well. So the scenario at the present time sounds, based on the complexity of this signaling, sounds extremely important in terms of the perspectives for our patients. Within this scenario, I would like to ask first Nadia, what are the data that tells us, what data that we have regarding the efficacy of CDK4/6 inhibitors in patients with hormone receptor positive disease, and what questions remain about the use in practice, particularly focusing, Nadia, in the patients with early disease?
I think we have one approval recently in Europe, a little bit earlier in the US for the Monarch E regimen of abemaciclib for 2 years, together with endocrine therapy in clinically high risk, that is node positive disease. And So the benefit here is quite substantial after an early follow-up of slightly over the treatment period. If you want, we have about a benefit of 4 to 5%, depending on what inputs you look at in which population. So very strong data here in the clinically high-risk population. We've had for another CDK4/6 inhibitor, palbociclib, 2 trials that didn't reach their primary endpoints, Penelope B after neoadjuvant therapy, and the Pallas trial as sort of parallel to the Monarch E trial, although in a slightly more intermediate to high risk population. These trials have been negative, but I think they will be very, very important together with their translational research to help us understand the role of CDK4/6 inhibitors in the early breast cancer setting. We're still waiting for results from a couple of trials. The Natalie trial has been fully recruited. It uses ribociclib in a 3-year duration at a slightly lower dose than it's used in the metastatic setting. So those will be very interesting data. And we have 2 trials in Germany still ongoing. One is the ADAPT cycle trial, which actually looks at patients following our ADAPT trial, where you really don't feel comfortable in giving them endocrine therapy alone, but you're not so sure that they will have a chemotherapy indication and that they actually will benefit from chemotherapy. So something like what we discussed before in the problem is in the luminal breast cancer. So ADAPT cycle randomizes ribociclib plus endocrine therapy versus standard of care chemotherapy and tests for superiority of the CDK4/6 inhibitor approach. And the second trial we have ongoing is sort of similar to the Monarch E trial with the abemaciclib, but asks the question, patients who are already on 1 year of endocrine therapy and up to 6 years out from their primary diagnosis, will they also benefit from adding abemaciclib to their endocrine therapy? So basically, that would give us a fuller picture of patients who benefit also later and during their follow-up period. It's called ADAPT Late, and it's also still ongoing. And then our UK colleagues still have a trial. It's called Poetic A, sort of following their Poetic trial with abemaciclib in those patients who do not have a good endocrine response in this short preoperative endocrine therapy. And they are looking at whether abemaciclib added to endocrine therapy will benefit those patients. So very interesting concepts that will give us a fuller picture of how we use these CDK4/6 inhibitors optimally in the early breast cancer setting. And I think also answer some of the still open questions like how late can you start? What is the optimal duration? Which patient collective benefits? Does endocrine response play a role in the magnitude of the benefit? All of these questions, I think we just need to be a bit more patient, wait another year or so, and then we can have more answers to that.
Certainly more than a year, Nadia. Certainly there are many, many questions that have been raised, whether you can substitute chemotherapy in some of these patients by optimizing the endocrine therapy in that regard. Certainly what happens after the recurrence of these patients, if they recur, having received CDK4/6 inhibitors, and the sequencing there also. But let me ask Chiun-Sheng a question in terms of what is his impression in Taiwan and Asia in general, were the introduction of the concept of abemaciclib being effective in this group of patients with high risk early breast cancer? And what's the impact you feel that's going to have in your region in terms of improving the management of these patients?
Okay, thank you. I think we all know that the CDK4/6 inhibitors, the studies of these drugs actually first developed in postmenopausal patients. And then for the ribociclib, they have the Mona Lisa 7 that focus on premenopausal patients. And actually, that is the first study to have the overall survival benefit to show the benefit. But then for the monarchy study, again, we see that how much benefit that can be achieved in premenopausal patients. I think in the recent poster, just presented in ESMO breast. It shows that probably the benefit for premenopausal patients is even at least numerically is greater in premenopausal patients than postmenopausal patients. And compared to the Western countries, I think most Asian countries has lots of premenopausal patients. And actually in Taiwan, we have probably around 50% of breast cancer patients are premenopausal patients. So we are glad to see that for the premenopausal patients, they also benefit from CDK4/6 inhibitors. And actually, for the responder studies, we noticed that for premenopausal women, even lymph node 1 to 3 metastasis, they also need chemotherapy. That is quite different from postmenopausal patients. So I think we are great to see that the premenopausal patients also benefit from abemaciclib. So I think that is a great news for the patients in these regions.
Thank you, Chiun-Sheng. Fantastic comment. And let me finish with a last very provocative question looking at the future, Nadia. Certainly, the complexity we mentioned a few minutes ago on the endocrine signaling pathways and the interactions that we have been discovering lead to the development of new alternatives. How do you see this new oral SERDs, this large number of drugs that are being developed in the scenario of hormone receptor positive, HER2 negative early breast cancer?
Oh, I love to have an oral SERD available for my patients because, as you know, fulvestrant is a great drug, but some patients just can't have these injections. Some patients refuse the injections. So having an oral SERD or several oral SERDs available and being able to sort of modify the regimens according to the patient's preferences and patient's need would be fantastic. Having said that, we've heard about these substances for quite a while. We've seen a positive trial at the San Antonio meeting in 2021, but we also saw in that Emerald trial that the late line setting is too late for an endocrine monotherapy because a lot of these patients in the experimental as well as in the control arm relapsed at the or progressed at the first restaging. So it's going to be difficult, I think, to develop these oral SERDs, in particular into the early breast cancer setting, now that we have these wonderful options with the PARP inhibitor or with abemaciclib, according to the Monarch E data. So it's going to be a challenge to find the right setting to prove superiority to what we already have. And if you ask me clinically, I would be happy just with a non-inferiority trial with good safety, because I think the advantage of having a SERD in an oral form is self-explanatory.
Yes, fantastic. Certainly, very important perspectives. And looking at the future, the possibility of adding new alternatives that interfere with endocrine signaling certainly will add into our ability to treat these patients with better and optimal choices, as you mentioned, improving the administration of drugs like fulvestrant. If I may summarize this extremely interesting perspectives looking at the future, certainly the efficacy of CDK4/6 inhibitors in this setting has been mixed, with negative results with palbociclib in a couple of trials, as Nadia mentioned, and positive results for the Monarch E that seem to be maintaining the results as a positive results as the follow-up continues to evolve. So we will need to see, and the incorporation of this treatment in the guidelines certainly points to a promising future, improving the results, at least at this high-risk patient population. Important to recognize that there are ongoing trials that probably will inform us of how to best manage these patients in the future. And some of these trials probably will not only answer some questions, but raise some other questions that we would need to continue to answer in future clinical trials. And as Nadia mentioned at the end, we should all be very attentive of what's happening with this surge that probably in the different number of trials with different strategies that are being utilized will probably end up having some impact. It's still unknown exactly what degree of impact they will have, but certainly I am positive that we will be improving further the prognosis and the treatment of these patients with high risk of recurrence in this situation. Let me thank everybody for being here with us during this program. I hope you enjoyed it. Let me thank in particular Professor Huang and Professor Harbeck for an excellent participation. It was a really pleasure to be here with all of you.